In this lecture, we'll be wrapping up musculoskeletal. Osteoporosis is going to be a metabolic disorder with loss of bone mass. Women are at greater risk for developing osteoporosis. They have less bone mass to start with, and age-related bone loss begins earlier and proceeds more quickly in women. Aging, think about the reductions of estrogen that promotes osteoblast activity and low testosterone levels in men. Race, European Americans and Asians are going to have an increased risk. Hyperparathyroidism, the PTH is going to pull calcium from the bones. Cushing syndrome, that also increases osteoblast activity, and calcium and vitamin D deficiency in the diet. Renal failure can also cause this due to a loss of active form of vitamin D and a tendency towards acidosis. So acidosis is going to draw calcium from the bone and neutralize pH. Alcohol, that suppresses osteoblast activity. Cigarette smoking is going to decrease the blood supply to the bones, slows osteoblast activity, and impairs calcium absorption. A sedentary lifestyle, that's going to decrease blood flow to the bones and decreases osteoblast activity. And medications such as corticosteroids for greater than 3 months and some anticonvulsants as well. And then large amounts of diet soda and caffeine. So the manifestations of this, they're going to have a loss of height, their vertebral bodies will collapse, some low back pain, and progressive curvature of the spine. That's called dorsal kyphosis. It's an increased thoracic curve or a humpback, and cervical lordosis that constitutes a dowager hump. The abdomen tends to protrude, and the knees and hips flex as the body attempts to maintain the center of gravity. And we can see that in this picture right here. Osteoporosis can cause fractures of the arm, the vertebrae, or even the hip, and there may not be any other signs until the fracture occurs. This can be spontaneous, or it can occur with everyday activities. Diagnostics for this, they're going to be doing an x-ray, dual energy x-ray, that's called a DEXA scan. And that's going to measure bone density and lumbar spine or the hip, and it's highly accurate. They can also do an ultrasound of the heel of the foot. It's not going to be as sensitive as a DEXA scan, but it's okay as a screening tool. A bone mineral density, that is going to be used to estimate skeletal density in patients that are at risk for osteoporosis. An adequate intake of calcium and vitamin D beginning in childhood is going to be critical to preventing and treating osteoporosis. We want to really prevent this before it starts. So 1,000 to 1,500 milligrams daily in divided doses can increase absorption. So calcium carbonate, such as Tums, you can take that before meals, and that helps increase calcium absorption. Calcium citrate, you want to take that with meals to decrease any GI upset. Vitamin D, that's 200 milligrams a day, that is needed to increase GI absorption of calcium. So a lot of times they will have these two together in the same medication. Fluoride, that decreases osteoclast activity, and that's when the osteoclasts, they were the ones that remove bone tissue, and the research and use of this is relatively new. HRT, that's hormone replacement therapy like estrogen, that's going to decrease bone loss and increase bone density. Estrogen alone is going to increase the risk of endometrial cancer, so it's often combined with progestin. One example of a medication for this would be tamoxifen, which is a selective estrogen receptor modulator, and that mimics estrogen without the risks of estrogen. Sometimes you'll see that used for cancer treatment, but can also be used for osteoporosis. Aldronate or Fosamax, all of these are going to have the dronate in the suffix here. So these are going to prevent and treat osteoporosis, decrease osteoclast activity, and increased osteoblast. And that's going to be building the bone tissue activity. So osteoclast removes the bone, and osteoblast helps build the bone tissue. You're going to give this with water alone, and you want to give it 30 minutes before food or other liquids. When you're giving this medication, the patient must be upright for about 30 minutes with no meds with calcium within about 2 hours. This can cause esophagitis, and it's not for people with renal insufficiency. Calcitonin, that's a hormone that increases bone formation and decreases bone reabsorption. Typically, this is produced in the thyroid gland, and it's available as an injection and a nasal spray. The nasal route, they must alternate the Nair daily, so they need to use that like one day the left side, the next day the right side. And nausea and vomiting can occur initially, but that will pass. Commonly, this causes rhinitis. Watch for allergies. They can have anaphylaxis, and observe for side effects such as nausea, vomiting, anorexia, flushing of the palms and hands, and urinary frequency. And then NSAIDs, we really want to avoid those. They may hasten the disease process. We're going to educate to avoid due to causing an increase in bone destruction. And really, NSAIDs, a lot of the orthopedic surgeons, the PAs, they will recommend that their patients stay away from NSAIDs. Health promotion, we want to encourage dairy products, green leafy vegetables, oysters, and salmon intake. This is important for young women to increase intake at the optimal bone mass peak, and that's going to be from 25 to 35 years of age. Exercise, weight-bearing activities 3 times a week for 30 to 40 minutes. The stress increases blood flow to the bones and increases osteoblast activity, and that helps the bones to absorb more calcium. And then healthy behaviors like limiting alcohol, no smoking, and limiting caffeine. Gout is a metabolic disorder. This is the overproduction of uric acid and crystals or urate deposits. And these are going to be deposited in the tissues. Unless it's treated, this is going to progress in stages. In the beginning, they're going to have asymptomatic hyperuricemia, and that's when serum levels will start to rise. Most people do not progress past this stage. With acute gouty arthritis, this is a flare-up, and it's typically affecting one joint. It occurs unexpectedly and beginning at night. It can last for several hours to days, up to about 10 days. These clients can have asymptomatic intervals between attacks, so they can go about 10 years before having another attack. And then lastly, there's tophaceous gout, which the way I remember it, it kind of sounds like toe, and a lot of times gout is in the toe, so tophaceous. That's going to be advanced gout, and that occurs when hyperuricemia is not treated. They'll have tophi, which is uric acid deposits. They're going to develop in the cartilage, tissue surrounding joints, and along tendons, fingers, and ankles. So the tophi can restrict joint movement and compress nerves and erode through the skin. They're also quite painful. Acute gouty arthritis, about 50% of those attacks are going to be in the metatarsal pharyngeal joint of the great toe. They're going to have acute pain, elevated WBC count, and an elevated SED rate, fever, and chills. The joint's going to be swollen, red, warm, and painful. Tophi are going to develop in the cartilage, tendons, and soft tissue. They can also go to the heart. Although tophi themselves are not necessarily painful, they can ulcerate, restrict movement, and compress nerves. Usually when I see these causing pain, it's because of nerve compression. Without treatment, the uric deposits will form in the renal parenchyma and the renal tubules, and the renal tubules can then create renal stones and obstruct flow. And attacks from this can be quite painful and long-lasting. They can be from hours to, well, we kind of already talked about that, days, sometimes even weeks, depending. So diagnostics for this, Diagnostics for this are going to include an elevated uric acid level, WBC count of up to 20,000, elevated ESR, that's going to show inflammation, and you can do a 24-hour urine to determine uric acid production and excretion. For an acute attack, we're going to be giving some colchicine, and this is going to be given frequently until the patient starts having significant side effects. Some of that's going to include abdominal cramping, diarrhea, and nausea and vomiting. When we give this medication, a lot of times the pain that the patients will experience from gout is going to diminish within about 12 hours. NSAIDs, like indomethacin, indocin, you'd give about 50 milligrams of that every 8 hours. That's going to be what's most frequently prescribed, but they can also use other NSAIDs as well. Analgesics, codeine, Vicodin, Darvocet used to be one of the standards, but they don't give that one anymore. Not aspirin, though, because that can further increase uric acid levels. So we don't want to give aspirin for this. Corticosteroids, they would do interarticular, so that's going to be within the joint, and that can be prescribed to avoid system effects. Bed rest during the acute attack and some ice, elevate the affected joint, protect the affected joint, increase their fluids. So you want to make sure that you're increasing urine excretion and reducing the risk of renal stones, and dietary purines. So that can contribute a little to elevated uric acid levels. So if a dietary purine is restricted, high purine diets include meat, seafood, yeast, beans, lentils, oatmeal, spinach, asparagus, cauliflower, mushrooms. There's more, but those are going to be just the basics. And then uric or suric drugs are going to block the tubule reabsorption of uric acid, and that promotes the excretion and reduces serum levels. The xylopram here, sorry about that. The xylopram, also called allopurinol, this is not going to be used for treatment of asymptomatic hyperuricemia because of the effectiveness of lowering serum uric acid levels can trigger an acute gout attack. Allopurinol can increase BUN and creatinine, hypersensitivity, and rash can occur. And here's a picture of somebody with gout. You can see the redness on this joint here. This can be pretty painful. You would want to encourage bed rest, elevation of the extremity. Sometimes with these patients, I'll end up getting them a foot cradle for the bed. That looks like this, so this just hooks to the bed. There's a lot of different types, but this is one you would see at Unity Point, and this just allows the covers to rest on this part of the cradle instead of on the foot. And you can use these for foot surgeries, amputations, gout, all sorts of things. It's just one of the measures to help reduce pain in that joint, because it does look quite painful. Osteoarthritis is also called degenerative joint disease, so you'll see DJD or degenerative joint disease or osteoarthritis or OA. So along with damage to the cartilage, these patients can develop osteophytes. The cartilage and bone beneath will erode and cause osteophytes. They're also called bone spurs. Bony overgrowths, and then they can break off and cause synovitis, which is going to be an inflammation of the synovium lining the joint. This can be localized or generalized. With localized, it's going to affect 1 to 2 joints. With generalized, it's going to be 3 or more. It can also be primary or secondary. Primary is going to be idiopathic in nature, and secondary is going to be from an injury or other associated factor. There's a few different risk factors for osteoarthritis. Advanced age is going to be one of them. Over 90% affected by the age of 40 years old, but they do not experience signs and symptoms until after about 50. This can be due to joint thinning as age and loss of muscle and ligament elasticity. Genetic predisposition, so if you have a family history of this. Increased weight, especially for joints of the hip and the knee. repetitive use. Think about those that are active in sports. Decreased estrogen, so postmenopausal women are going to be at risk. Inactivity. Think also too about repetitive motion, so jobs with the same bending motion or heavy lifting or a lot of the same movements over and over again. So joints most affected include the hands, especially in postmenopausal women, the hips for men, the neck, lower back, and the knees. The manifestations of specific joints are going to depend on the area. Joints become enlarged with bony overgrowth, have flexion contractures, and the joint's going to be, that's when the joint is going to be fixed in a bended motion. This often involves crepitus, and it can even occur at the base of the thumb or the knees. So these are going to be the ones that, with the crepitus of the knees, that you're going to hear that grating noise every single time they go up and down the steps. They're going to have limited range of motion, and it's going to be worse after being stationary. So waking up in the morning or getting up from a chair or out of the car, really sitting for extended periods of time is going to set this off. They could have Herbern's nodes, and these are bony enlargements of the distal interpharyngeal joints, so you're going to see those right here and right there. And then the Bouchard's nodes, which are bony enlargements of the proximal interpharyngeal joints. See that one right there. Physical examination and patient history can potentially identify osteoarthritis, and x-rays are going to show changes in the joint space and possible osteophyte formation. And there we see an osteophyte right there. That's a bone spur. In some cases, they may also do an MRI to determine the extent of joint damage, as well as other studies. So they could aspirate synovial fluid from the affected joint, and that can rule out other types of arthritis. They'll do that sometimes with gout. For nursing care, you're going to be doing a cold spa. You're going to be assessing their pain. Also, their functional mobility. Can they still perform their ADLs? So if they're not able to, this is where you would do a consult to probably OT for ADLs, possibly PT, depending on what joint is affected. So you want to make sure that you get these patients to the point where they can take care of themselves. You're going to administer medications to help with the pain. So Tylenol is preferred for long-term use, especially with the elderly, because it's going to have fewer side effects. Be very cautious with your NSAIDs. They do treat inflammation, but there's a lot of risk factors. Well, we've talked about a lot of them throughout our lectures for NSAIDs. Interarticular injections, that's going to be an injection into the joint space of the affected joints, and this can be done every 4 to 6 months. This is going to be used with a long-acting steroid and lidocaine for pain, but these also accelerate cartilage degeneration. So what you'll see with these patients is they tend to need them more often the longer they're being treated this way. And I'm seeing an increase in popularity for joint rubs, muscle rubs, capsaicin, and topical NSAIDs. Like one of the topical NSAIDs you can use is diclofenac potassium, and that's a cream that you would rub over the joint. And I see it being pretty successful with patients. And evidence has shown marked benefits for those over the age of 75 years of age with topical NSAIDs for osteoarthritis pain. So you're going to be teaching about their medications. You're going to be including activity in that education as well. Include PT for range of motion, OT if it's for ADLs. And think about it this way. Your PT is going to be your big muscle groups. Physical therapy is going to work on walking. So the big muscle groups. OT is going to be fine motor skills. So occupational therapy with ADLs. Elevation, rest of the affected joint, assisted devices, whether that be a cane or a crutch. Again, PT will help you with that, and water-based exercises. And then diet, weight loss if indicated. Arthroscopy in the treatment of osteoarthritis is a little bit controversial. It can be used to remove large pieces of debridement or repair torn cartilage, and it can assist in delaying surgery. It can be under general anesthesia, spinal or local. A lot of times it's going to be under a local, and they're going to be introducing a scope through an incision. Sometimes they're just doing these to inspect, so they're doing them to get into the joint and see what type of damage is there. They're able to visualize and manipulate tissue and remove debris, like what we talked about, irrigate, take samples. They could aspirate fluid from the joint at the same time. They can also do an ostectomy, and that's O-S-T-E-T-O-M-Y. That's going to be an incision of the bone to realign the affected joint and shift wear to a less damaged area of the joint. This can delay a need for surgery or joint replacement for several years. This is going to be an arthroplasty, which is a reconstruction or replacement of the joint, and that's indicated when the patient has severely restricted joint mobility and pain at rest. It could be a partial or a total. So if it's a partial, it's going to be a hemi, so hemiarthroplasty. So when it comes to the hip with the hemiarthroplasty, that's going to involve replacement of the acetabulum or the femoral head. Looking at this section right here, there's the acetabulum, there's the femoral head. Again, that's going to be a hemiarthroplasty. With a total, they're going to replace both. A total hip is the one that's going to be most often done. Sometimes they'll use cement with these. Mostly they don't, but on occasion you will see it. And that's going to line the acetabulum where the cup is placed and the anchor metal seam. So in this area right here. The advantages, this allows for quick stability of the joint. The disadvantage of this is going to be it can fragment over time, and that it can initiate an inflammatory process and cause problems. Uncemented prosthetics, they require 6 weeks for new bone growth to secure, so longer non-weight bearing during that time frame. And I just want you to pay attention to this part of the picture right here. When they are replacing the femoral head, this is drilled down into the bone. And these can last about 10 to 15 years before requiring a revision. So nursing care is going to focus on pre-op teaching mostly with these patients. You're going to assess knowledge of the procedure, obtain health history, physical assessment, explain post-op restrictions. They might have different types of weight bearing depending on what type of surgery they had. Post-op exercises, respiratory hygiene, incentive spirometer, deep breathing and coughing, and pain control is going to be a big one with these, and antibiotics as ordered. So you're going to educate them on all that. Post-op neurovascular checks for every hour for the first 12 to 24 hours. Vital signs every 4. You're going to monitor respiratory status. Empty their JP drains or orthopacks. They could have a hemovac too. Just depends on the surgery. A lot of times they will have like a hemovac, which is, it hooks up to suction. You won't see those very often though. If you do, ask your instructor to show you about them. Reinforce dressings as needed, and the doctor will usually change these about 24 to 48 hours. Maintain proper positioning to avoid dislocation, so these patients need to be educated on that. You don't want them to go over 90 degrees flexion. Get them out of bed as soon as possible in order to prevent complications. So PTOT is going to be getting these patients out of bed that day. Labs, CBC, PT-INR, you want to monitor for complications, infections, DVTs, PEs, prosthesis loosening, and dislocating. And then meds, analgesics, NSAIDs, antibiotics, stool softeners, and anticoags. So these patients are going to be on DVT prophylaxis. Usually it's a Rixtra or Lovenox. Sometimes you will see them on an oral anticoag. Nursing care, their activity is going to be non-weight bearing or toe touch weight bearing with an assisted device. You want them to make sure that they're shifting their position every 2 hours. Sometimes they will give them an overhead trapeze bed to help get them to move around in bed independently. Prevent hip flexion over 90 degrees. If they go over 90 degrees, and sometimes you need to be careful about what chair you have them sit in, that hip will pop out, so it will dislocate. Use your abductor pillow, maintain good alignment, no crossing of the legs. Sometimes when these patients are in terrible pain, it's because they're cockeyed or crooked in the bed, so teach them about that. Adaptive equipment. PT is really good about going over adaptive equipment with them to help them maintain their weight-bearing status. So NWB is going to be non-weight bearing, and TTWB is going to be toe-touch weight-bearing. A lot of times people have more difficulty with this, the toe-touch, than they do with the non-weight bearing, because it's kind of hard to determine how much weight you're putting on that leg. Because of the 90-degree limitation, no rocking chairs, so you want to make sure that you're not putting them in a rocking chair or a chair they're going to sink into at home. Tall people, they may need a seat elevator or an elevated commode, and special care getting in and out of the car, so you don't want them to bend more than 90 degrees. Watch for signs and symptoms of dislocation, so look for shortening of the limb with internal rotation and pain, and they should be carrying an ID card for their prosthesis, especially when going through like airport security. Encourage high protein. We want to help these patients heal faster. Vitamin C, iron, and high fiber. Think about the narcotics that they're on. Miscellaneous IV fluids, support stockings, ankle pumps, SCDs. We want to make sure that we are doing DVT prophylaxis. I don't know why that's spelled wrong, but that's going to bother me. Incentive spirometer. Prevent atelectasis, and of course the ID card. There is a trend that's happening right now with healthcare and joint replacements. It's been going on for like the past year and a half or so. These patients, a lot of times, they get discharged from the hospital within 23 hours. So they're considered observation. You might not be taking care of a whole lot of these. The ones that get admitted are the ones for hip fractures. So knee replacements, unless it's a bilateral knee, and hip replacements, unless it's a bilateral hip, a lot of times they'll go home within a day. Complications, know your signs and symptoms for dislocation. So pain with internal rotation, they could have a shortened leg. Infection, they may have an increase in white count, fever, drainage. They're going to have some drainage around the incision site. They're starting to use these newer bandages, surgical bandages that will stay in place for about 10 days. So you're not going to be taking those off, but if you see drainage through them, you would notify the physician right away. They may need, if they do get an infection in that joint, they may need to remove all the hardware and start over. So that would be a repeat surgery for those patients. So you want to make sure you jump on infection as soon as it starts and get your patient on antibiotics. Bleeding. A lot of times these patients are on blood thinners afterwards as a prophylaxis measure, so they have increased bleeding times. Pneumonia, think about your post-op complications, get them up, get them moving, get them using the incentive spirometer, and deep breathing and coughing. DVT and PE, that is another post-op complication they can have. This is the reason why we've got SCD pumps on them. We've got our anticoags in place, like our Lovenox, our heparin, our Rixtra. Lots of different things we're doing here. So know your signs and symptoms for DVT and PE. And then, of course, in ileus. We talked about ileus a lot with the GI section. So make sure that you are aware of post-op complications that can result in an ileus. So know your signs and symptoms for all of those. And then also, too, think about minor complications like nausea. So side effects of narcotics, they can really trigger nausea. So keep aware of that. Nausea, vomiting, we want to make sure that your patients are able to tolerate taking liquids. Itching, they could have itching from narcotics. So morphine is notorious for causing itching, so they might need some diphenhydramine for that. Respiratory depression, you want to monitor your patient, make sure you're not giving them too much narcotics. Respirations less than 10, you might need to use some Narcan on them. And decreased level of consciousness too. Lots of things to monitor post-op. Rheumatoid arthritis. Rheumatoid arthritis, or RA, is an autoimmune and inflammatory disorder of the musculoskeletal system that's characterized by a diffuse inflammatory lesion and degenerative changes in connective tissues. The rheumatoid factor is going to be the presence of antibodies from exposure to an unidentified antigen, kind of like a virus. This causes immune response in genetically susceptible hosts, causing normal antibodies to become autoantibodies and attack host tissue. This is going to be systemic and polyarticular, so that's going to involve many joints in both extremities. Patients can also have systemic manifestations. They're also called extra-articular manifestations. These include fatigue, anorexia, weight loss, and then nonspecific aching and stiffness, low-grade fever, anemia resistant to iron therapy, and muscle atrophy around the affected joints. Systemic manifestations usually precede joint symptoms, joint swelling with stiffness, warmth, tenderness, and pain. Inflamed joints are going to feel boggy or spongy, and that's likely due to an increase in the synovial edema. They end up having some deformities. They'll have a swan neck deformity. That occurs at the base of the index finger on top of the outermost part of the hand. The Guiner's deformity, that's going to be the distal fingers, and then ulnar deviation is going to be when the outermost part of the hand curves inward. Diagnostics for these are going to be based off physical exam. RF, so the rheumatoid factor, that's going to be present. They'll check anti-CCP blood test, and that's going to be a specific marker for RA. Lab tests are going to be used to measure the levels of antibodies. C-reactive protein, ESR, which is going to look at the SED rate, that's going to be elevated, and this is going to show inflammation. An X-ray will show narrowing joint space and erosion, and then they will aspirate the synovial fluid. So that's going to be examined, and then it'll have characteristics of inflammation like WBCs, it'll be cloudy, and it'll be turbid in appearance. And a CBC will show mild to moderate edema and elevated platelets. About half of these patients with RA are going to experience some type of disability within about 10 years of onset, and the life expectancy is also shortened. Treatment, there's going to be a fine balance between rest and exercise. They may need extra rest with an exacerbation, and movement's going to help promote balance and maintain muscle strength as well as joint mobility. You want to get PT and OT with these patients, especially to preserve function in their ADLs, and they are really good with working with them outpatient even. So there's a lot of outpatient clinics that'll work with them. Heat and cold, whatever's going to work for the patient. Moist, warm heat is usually the best, and a warm bath as well. And then cold applications before exercise can help decrease joint pain. Assist devices, again, PT is really good about helping patients with this. They might need a cane, a walker, some cases a wheelchair, a raised toilet seat. And then splinting, that's going to provide joint rest and prevent contractures. Encourage a balanced diet, and some people will increase omega-3 fatty acids like their fish oil in their diet. Surgery, removal of the synovial membrane can help give temporary relief of inflammation, pain, and even slow down the destructive process. In extreme cases, they might also perform a joint replacement. Many different types of medications here. Aspirin and NSAIDs, you need to think about what your risks are for these medications. Look out for GI distress, peptic ulcers, GI bleeding, and they really don't have much effect on disease progression. I would recommend, if they're going to be taking this every day, maybe use an enteric-coated aspirin to decrease any GI effects. Corticosteroids, those can relieve signs and symptoms and slow progression, but they have a lot of adverse effects. Some of that's going to be poor wound healing, increased risk for infection, osteoporosis, GI bleed. They can also have a severe rebound effect, which can cause fever and muscle pain, joint pain, and that makes it hard for a provider to differentiate between withdrawal symptoms and a flare-up. Then we have disease-modifying drugs. These can slow disease progression, but they're fairly toxic and require close monitoring. The gold salts, they're going to be taking that PO or IM, and the mechanism of how this works is pretty unclear, but they also cause gastric distress and stomatitis, proteinuria, and bone marrow suppression. So they need to be monitored closely, CBC, UA. You're trying to prevent some of the side effects from that. Plaquenil, that is going to be an anti-malaria drug. This can take about 3 to 6 months of therapy to achieve a desired response. It can cause vision problems, so they require a vision test every 6 months with this. Sulfasalazine, that's going to be used for Crohn's disease too, and ulcerative colitis. Causes some CNS and renal and liver toxicity, and it can cause nausea and vomiting, as well as neutropenia and thrombocytopenia. So they need to be monitored closely for that as well. The penicillamine, that can cause bone marrow depression, proteinuria, and nephrosis. So you're going to monitor your CBC and your UA. Immunosuppressants, methotrexate, that's a folic acid antagonist that's used with cancer treatment. So they're going to need concurrent folic acid or leucovorin, which leucovorin is going to reduce some of the adverse side effects. So it depends on how much methotrexate they're on. What they'll do is they'll give them the methotrexate and follow it up with something called leucovorin rescue. Cyclosporin, that's going to be an immunosuppressant used with organ transplants, and these are nephrotoxic. And then monoclonal antibodies. So Remicade is going to be a good example of this, and this works by blocking your immune system's overproduction of a protein called tumor necrosis factor, and that's a primary cause of inflammation. It's used for RA, Crohn's disease, ulcerative colitis, but there is an increased risk for developing cancer with this medication. Systemic lupus. This is going to be a chronic inflammatory autoimmune defense that affects almost all body systems. This includes musculoskeletal. The etiology of this is going to be unknown, but they're thinking that sometimes genetics, environmental, and hormone factors are going to play a role with this. Lots of manifestations with these. We'll break it down a little bit by system. So in tegmentary, they're going to have photosensitivity. They should avoid the sun and use an SPF of 15 or stronger. They're going to have this butterfly rash on their face, and then various skin disorders and lesions. They could also suffer from alopecia and ulcers around the mouth and the nose. For renal, 50% of these patients will end up developing renal disease or nephrotic syndrome, and about 10% are going to develop renal failure. This can be a common complication in lupus nephritis, especially when a patient's taking corticosteroids. Neuro, they could have neuropathies, seizures, depression, psychosis, and dementia. For respiratory, pleurisy, pneumonitis, interstitial fibrosis, sorry, I said intestinal, it's interstitial fibrosis, and pulmonary effusions. Cardiovascular, vasculitis, endocarditis, pericarditis, and myocarditis. Musculoskeletal, arthralgias, joint swellings, and morning stiffness. And reproductive, they could have fetal loss, proteinuria, and I didn't mention this earlier, but also hypertension and edema. So major systemic symptoms with lupus. They're going to be running an ANA, which is an anti-inflammatory nuclear antibody testing, and that's going to be positive in about 98% of the patients. But an anti-DNA antibiotic is going to be a little bit more specific for this. And a CBC is going to show mild to moderate to severe edema, just depending on the disease progression. Leukopenia, so decreased WBC count, and low lymphocytes as well as an elevated ESR. Treatment, you're going to be giving Tylenol, aspirin, and NSAIDs. That can help manage the joint pain, the arthritis, fever, and fatigue. And aspirin is going to help prevent thrombosis in patients with SLE, but keep in mind that can lead to liver toxicity. Plaquenil can be used to treat skin and arthritic manifestations and can help decrease any acute episode frequency. Corticosteroids, those are going to be required for those who are exhibiting life-threatening manifestations such as nephritis, hemolytic anemia, or pericarditis. And they're going to require large doses of corticosteroids in those events. And if possible, you want to make sure you get those patients weaned off of there, because remember how many different side effects those steroids have. And immunosuppressants, they're going to be used in conjunction with steroids to decrease side effects because you can use them in lower doses. You need to administer those with food, monitor renal function, liver function, WBC and platelet count, and notify the provider if the WBC count falls below 4,000 or platelets below 75,000. Use meticulous hand hygiene with these patients, monitor for infection and bleeding, and strict INO with them. You want to be able to detect any kidney problems early. Okay, so this wraps up this section. I'll get you guys a study guide posted for the test as soon as possible, and have a great night.